And but moderators will be the same, moderators and expert panels. In this session, it is called the Let Us Discuss a Case. Here, Dr. Suresh, Vijan and Dr. Rajpal will be discussing. The first speaker, he will show his case, and then the second speaker shall discuss his strategy for the case. And finally, again, the first speaker will show how he finished that case. So this is a model of presenting a case. Shall you, what will I, well, I think this will have a good discussion, and I think we'll just go to the session. Along with that, we can discuss this topic also. This is basically because of the lack of time, we are already 9 now. I think we'll try to finish this session and then go for the final discussion. And I request Dr. Bahulian, Sahu, and others to just take over this session and go with this case discussion, please.
Dr. Sahu, please.
Yes, I would. Good evening, everybody. In fact, we have just heard a very nice lecture from Madam, and I would request Dr. Vijan to please proceed with the case, because this is he'll try to highlight about what he did in the case of LED ISR and RCA ISR. Dr. Suresh Vijan is a very senior cardiologist, and we have known him from our student days in Bombay. He is attached to the Lilavati Hospital and is also one of the directors of the Bifurcation Club of India. Over to you, Dr. Vijan.
Can you see my slides, Dr. Bahu?
Yes, your slides are visible.
Okay, great. All right. Okay. First of all, I must thank Dr. Selvam to asking me to present this case of in-stent renosis for this excellent meeting. The lectures have been fantastic. Congratulations, Natalia. I think that was excellent overview of OCT for bifurcations, which kind of nicely leads on to my case. This is a young 63-year-old male patient who presented in the middle of the COVID epidemic with acute anterior wall infarction of 2 hours duration. Non-smoker, non-diabetic, mildly hypertensive, but dyslipidemic since 1998. He had a previous PTCA to RCA with a bare metal stent in 1990, followed by another PTCA to LED with a cipher in 2008. Has been on PSK9 inhibitors for the last 1 year, with lipid levels being very well controlled. Came in, we managed to process him despite COVID within an hour and a half onto the cath lab, and here's his angiogram. That's the left coronary artery. And you can see that the distal left main proximal LED, there's a stent in the LED, which has got in-stent restenosis with a total occlusion in the middle of the stent with no flow down there. He's also got an ostial circumflex lesion. There's a large diagonal there, which appears to be, ramus there, which appears to be reasonably free of disease. But you can see fairly diffuse in-stent restenosis with total occlusion here.
Yeah, Dr. Suresh, can you go to the full screen mode, please?
Just trying to do
slideshow. Yeah.
That's okay, right.
Now excellent, correct.
Okay. And that's the view. You can see there's a tight stenosis, also the ostium of the diagonal. That's the iliocranial. You can see an ostial LED also. And of course, there's a diffuse in-stent restenosis of the RCA for the previous bare metal stent. Question is, how do you proceed with this case? Over to you, Dr. Hyde. Dr. Vijan, it's all yours now to talk about how would you do the case?
Hello, am I audible?
Yes, you are audible.
This is Dr. Rajpal, and I've had an opportunity to discuss this case with you, and I've seen the first clip that you showed where you stented where you did a POBA and dilated the in-stent restenosis and did that. So would you like me to tell you what I would have done, and then you can go ahead and show what you did?
Please.
Yeah. So this is an LED bifurcation, LED left main diagonal bifurcation, and you can see that the left main ostium tapers. Left main ostium is very wide. It tapers to a distal bifurcation. You have an LED ostium which is very tight. I saw your angiogram. It's very well done, where you showed us that you did the LED first, waited for a few days, and then did the left main diagonal. Is that right, Dr.
That's
Suresh?
correct. That's correct.
Yeah. So would you mind showing us what you did? Because up to that point, I agree with you. And then, maybe I have a few different thoughts. So would
Okay.
you like to show us that?
Yep, I'll proceed.
Yes, please.
Okay, so the whole point in our minds at that time was deal with the mid LED occlusion, which was an emergency, and stage the rest LED leave RCA for a different date. Deal with the LED left main all in one go, which a lot of us were not very happy about. Stage the RCA, just do the palming, take care of it. These are two instant restenosis, and then take a surgical opinion before we do anything about dealing with that left main. So we proceeded to do the LED, which actually was pretty straightforward. Here we go. I'm just going to show you the final result of the LED. What we did is passed a wire through, took a thrombus catheter, and I was not surprised when I sucked out a lot of thrombus from that LED. So despite there being instant restenosis, there was a lot of thrombus there, sucked that out, took a 3 millimeter balloon, did a balloon dilatation, all the LED, leaving the ostium of the LED untouched, leaving the left main untouched. And that's the final result from just ballooning and yeah.
Dr. Suresh, we would like to see your final result. Yeah, it's
There
coming
you
up.
go. That's the result.
Yeah.
So that's the final result of the LED.
So, Dr. Suresh, this is what you have shared with me.
Yes,
And this was only a POBA, right?
that's only a POBA and nothing else. Patient settled down, ECG normalized, took him back to the CCU, had a chat with the family. I said, now you need to decide whether we want to proceed in the next few days to do a PCI of the left main LED and RCA. Do you want to take a surgical opinion? We encourage them to take a surgical opinion. They went to the surgeons. The surgeon said, yes, it's okay, but the circumflex is a non-dominant vessel. There are no OMs coming from the circumflex. It's not an artery that he's going to graft. So we should not worry about that artery at all. He said, just deal the left main LED and deal with the RCA instant restenosis, and it should be okay. So the patient's family then came back and said, we'd like to have a PCI done for that, for which we took him back to the cath lab to do the PCI.
Absolutely. What was the creatinine, Dr. Suresh?
About 5 days in between.
No, what was the creatinine?
Creatinine was 1.3. That was fine, and that's been always okay. Didn't go up at all.
Yeah.
So that's his angiogram before the PCI. Okay, and that's the RCA as it is, untouched. Okay, and now at this stage we discuss, should we image? Clearly it's a left main, I like to image. This is also an instant restenosis where I believe you must image to know what's going on inside the stent. And the issue was stent the whole LED from top to the proximal and ostium of the LED. Question was upfront two stent or single stent. We were convinced that the diagonal one was where the circumflex is not a dominant artery. Even if we lost it, there was no OM there. The ostium of the ramus was clear. There was no disease there. We'll confirm that with the OCT. So perhaps we said we'll go for the provisional stent, single stent, and if required, we want to do something to the ramus. Okay, so here we go. That's the picture. Okay, and now I'm going forward. Here's the OCT coming up now. And that's the OCT picture coming in now. You can see that with the marker there. Interesting what the OCT showed us. The next picture, I'll highlight certain areas of the OCT. You can see a lot of neointermittent hyperplasia. As you can see that quite thick. You can see the stent, the old stent is well expanded. This old stent is about 3.5 and remaining quite well. So the stent is all neointermittent hyperplasia that's occurred inside the stent. And you can see a lot of thick neointermittent hyperplasia, about 2.5 millimeters all around. So pretty thick. And we said we might have to use a cutting balloon or a scorer balloon or something to do that rather than anything else. And that's the picture we have. You can see that with the wire there. Took the measurements from the, you can see that the stent is actually widely open. So stent under expansion is not one of the reasons why this restenosis has occurred. This all pure neointermittent hyperplasia and neoatherosclerosis that has occurred. And this is interesting. At the site where the artery was completely blocked, this is what we saw, a ruptured plaque. So there was neoatherosclerosis too, which is the cause of his acute myocardial infarction. Pathologically confirms what's happened. Clearly made my decision. I knew I would have to stent this too at the same time. And of course, the measurement of the ostial LED of the left main going to 4.5. So we knew we had to size, so we said we'd take one stent from mid to proximal LED, another stent from proximal LED into the left main, use a 3 earlier, and then take a 3.5 and take, which is the Ultimaster which we use, which will go up to 4.55 on a pot without any difficulty. So that's what we proceeded to do. Balloon dilatation of all the areas, then a 3x38 from here, you can see that, balloon deployed, and then a 3.5x28 Ultimaster all the way to the ostium of the left main, and OCT run again. This is the OCT run around here. You can see that nicely in the longitudinal thing. Nice apposition of the stent all the way through to the left main. Sorry, it's not playing. Yeah, here we go. Now, one thing that is noticeable, and Natalie, you can comment on it. If you look at the thickness of the new internal hyperplasia between the old stent, which is there, and the new stent that's implanted, there's still fair amount of material there. I got concerned with that, though I have a very good luminal expansion. My new stent is well opposed, but there is still that thick material. What would we want to do about it? I decided to go in with a 3.5 balloon, squeeze it further. What else would people do about this particular issue here?
Yeah, Mike, I want to comment about that. My experience when the neo-intima is so fibrotic and is affecting the minimum lumen area is that even if you do NC balloons, if you don't do a scouting or a cutting balloon, that material is not displaced completely from your stent. And every time I try to do an NC balloon, I don't achieve that. So lately I'm changing my strategy. If there is circumferential, fibrotic, very, very thick neo-intima, I'd rather use a scouting balloon before. Otherwise, you get this image that your stent is still far from the old stent and a lot of material in between.
Yes, I mean, that was the concern. In fact, what we did was at the proximal LED, we use a 3.5 scorer because that material wasn't visible. So there we actually did a 3.5 scorer to get the whole thing. But as you can see, there is a fair amount of malposition in the left main, which is not surprising. It's 3.5 stent, the left main is 4.5. So we were going to go in and take care of that. Now here's a longitudinal picture. As you can see, the stent is nice all the way through till you come to the left main here. Now you can see that origin of the ramus artery here very nicely, some struts around here, and you can see this malopose stent pictures coming up. And that's the left main. So we took a 5.0 by 8 millimeter non-compliant balloon, did a pot at the bifurcation, pulled the stent back, balloon back, and actually also did a pot at the ostium of the left main. Then we did a run again here, and you can see that now it's all looking very nice and clear up to the left main without too many issues there. We've of course lost the diagonal. We did attempt to try and go to trial, but there's so much material between the two stents and the diagonal, no wire would go into that to give me any access to the diagonal. So yeah, that's your left main now, well opposed stents, and that's the set left main. Here, this is left main, that's ramus, and that's the LED. I just got another picture which just highlights what Natalie just mentioned in her talk. Here's the pre-pot with the 4. You can see a malopose stent. You can see these struts here. And here we've actually dilated with the pot, and look at what's happened to the struts. The ostium has become more open, freer of, moved all the proximal stent struts away, give a very clear view to access the ramus if that's what's required. So that's one of the kind of advantages of doing a proper pot in the left main, keeping of course well away from the ostia at the carina and making sure that the stent doesn't get compressed. So that's just something we saw, which is rather interesting. So that's the final angiogram of, that's the final ostial one again, and that's the final angiogram that you can see here. So any comments so far?
Yeah, Dr. Vijan, a very nice case. I think that the final pot which you have done, and it's a wonderful effect on the side branch, that ramus intermedius branch
Yes.
ostium is excellent. I think that is one thing which you should, the OCT helps us. One question to Natalia. Then provisional stenting approach in bifurcation, that side branch ostial coverage on the strut, the pattern of it, and kissing balloon inflation is not systematic, only in indicated cases. How the OCT imaging of the side branch ostium and its coverage pattern by the stent strut will decide for a further kissing balloon inflation? Is there anything like that?
Yeah, thank you for that question, because in my experience, if you had a big side branch as this ramus, once you do, and then the basal tapers naturally. So if you size your pod balloon well and you do a good pot, in your post PCI, you almost see how those struts are beautifully displaced into the abluminal side branch. And in those cases, the final kissing is not required. Like some people, every time they do provisional, they aim to do always kissing. And I think it's not necessary. And that's the beauty of imaging, because if you were able to clear up the osteum of the side branch with your pot, that's the work of the pot, right? Just getting you to stand up pose and open the struts into the carina to the side branch. If that's properly seen in the post PCI, honestly, I don't do kissing balloon in all my provisional bifurcation PCI. And doing it consistently, you have chance of dissecting a branch that is no disease. In this case, they show beautifully how the osteum of the ramus was never affected pre or post PCI, but it's because they size very well the stem, not only the stem, but the pod balloon.
Right, excellent, thank you.
Dr. Rajpal.
Yeah, I would like to say how I would have done this.
Sure.
For certainly, there are two things which come to my mind. One thing is we must think of wiring the ramus, because it is extremely unpredictable and nobody can decide pre-procedure when which vessel will close. So maybe I would have not wired the ramus, but I would have been very careful and put a wire in the ramus, because it is possible that this, even though there is no plaque in the ostium, it may shut down, number one. The second thing I would like to have done is, I strongly believe in a final kiss and a report. It is spot, kiss, spot. And the reason I believe so is that we have done OCTs on patients wherein we see that there is good, decent flow in the ramus after 6 to 8 months, but the patient has angina, and we see a slight haziness in the ramus ostium. And when we did an OCT, we find a thin film of tissue. And actually, this has been captured and described by the European Bifurcation Club. And so I would definitely end with a kiss. Now, the question can be, would you end with a kiss after having seen such a nice osteal opening after the pot? That can be questioned, but still I would end and go with the pot, kiss, pot, because I would not like to have this thin film of endothelium which runs across the ramus ostium. But otherwise, a wonderful case and very well done. And I strongly agree with Dr. Suresh, and the result has been truly very well done. And I also would like to know what efforts have been made to make sure that did you want to cover the ostium of the left main, or did you just
The stent all the way up to the left main ostium? Yes.
Sorry?
The stent is all the way up to the left main ostium.
Yeah, that's very nice. Which view did you select to make sure that you absolutely got the left main?
Right in the middle, iliocaudal, which shows it very nicely.
Iliocaudal.
Which is in the middle view here, clearly shows that very nicely.
Yes, well, that's a very good view to take, the iliocaudal, but iliocaudal is best to develop the left main bifurcation. So sometimes, maybe not in this case, you have done a great job, but it's very important to realize that the iliocranial or the PA cranial actually truly delineates the left main ostium, not the left main bifurcation. So it's a good job and very wonderfully done, Dr. Suresh.
I would just take that one point you mentioned about wiring the ramus and then doing a kiss. That is what we used to do all the time. Since we got the OCT and we could now see the ostia, and now that we do a proper pot based on OCT based arrangements, we are finding that we're not seeing stent struts across the ostium of the side branch, and therefore we stop doing that as a rule. Whether that is a correct strategy or not, I think we'll see as patients come back over a period of time.
Absolutely.
Okay, so now we proceed to the right, which is actually very straightforward. Straightforward wiring, OCT to the right again. This is what the right looks like. That's the tightest part of the lesion here, which is fibrocalcium. Again, you can see the stent is the old stent. With this bare metal stent, which is 22 years old, is well up, well open, nice size, and all that thing is tissue grown inside the stent with no rupture plaque. Of it, this is not an acute thing at all. Here we actually went with a 3.0 scorer because we would experience that what had happened to the LED, went with the C and actually scored that up, and then went in and put in a 3x33 millimeter. That's, you can see the kind of dense neo-interval hyperplasia all around in this particular case. And that's the reference size. So they went in there, dilated that, and that's a scorer there, and then went in and put a 3x33 millimeter stent, as you can see that here in the cut. Again, the same kind of thing that we notice, tissue between the two layers of stents, that was noticeable on the LLC side. Here again, despite the 3.5 scorer, this is what we saw. So that's, I don't know what we can do for this at all. This won't go away. We can try and compress it as much as you want to, but it's not really going to go away. It's there. But so long as we have a nice lumen in the middle, the stent is well opposed, I think we need to be just happy about that. There is some degree of malapposition here, which was corrected with another balloon inflation. And that's the final result. As you can see, the stent's nicely opened, well expanded. Here we got a good size, well approximated stent to the neo-interval hyperplasia, and with a good intraluminal flow. So that's what we are, and that's the final results. Angiographic results on both sides. Here we go. So there we are. Actually, 2 instant restenosis in one case. I think the advantage is the OCT really helped us size very well, understand the mechanism of the instant restenosis that's occurred, plan therapy accordingly. And of course, we need to now start scratching our heads to find out what we can do for this kind of internal hyperplasia that we actually see, which is very thick.
Suresh, sir,
Yes.
just to highlight, before taking a stent, do you do a OCT to make out how much preparation you have done? What is the lumen you have achieved?
We do that, yeah. We would do balloon it, to do an OCT, see what's going on, then take a stent.
Okay, then in that case, if you still left with some tissue, I think if you can go with a bigger cutting balloon or so, your sandwich will be lesser.
That's what we did to the right side. We went with the bigger cutting balloon. In fact, we went bigger cutting balloon even before we did a shot, because we realized we were going to have the same kind of problem in a much older stent anyway. So.
Yeah, but after putting a second stent, even if you dilate with a bigger balloon, I have seen that it doesn't expand. That
No,
sandwich thing.
I mean, I didn't see that much.
Yeah.
I think whatever expansion you could get had to come with the first preparation of the
preparation. That's right.
Absolutely.
Absolutely. Dr. Suresh, I agree with you. I was just wondering if you could show us that OCT run again.
Which one?
I absolutely agree with you. It's a wonderful result. And could we look at that OCT run again if it's possible, Dr. Suresh?
Of the RCA?
Yes, of the RCA.
I'll go back and see.
Please.
Yeah, that's the post.
Yeah, no, the pre.
Okay, let me just get that. Okay. Yeah, this is the OCT run of the RC.
Now, how did you reference your length? You chose your length.
No, that's not kept here. We took a 33 from, it was 18 millimeter old stent earlier, and we found that we had slipped both ways. So we covered from both normal to normal, take care of it.
Okay, absolutely. Okay, fair enough. I see that you really needed a little longer stent.
Yeah.
Oh yes, because so what happened is, because of the way the material was, the balloon would ping down, ping up. So we were going to create internal damage on both sides of the stent. So we said we might as well cover the whole area without having to worry about any other.
Dr. Suresh, what is the proximal portion of your stent? Are you happy with the expansion?
That's about 4.
Proximal portion of the stent.
Of the RCA stent is 4.
Yeah. Because I found that it is not to the preference.
If you see the first run, you'll see some malposition at the proximal end, which we then tied it up with the bigger balloon.
But even
But I
then,
guess you corrected the malposition.
Yeah, we did. Yes, the final doesn't show any malposition at all.
Absolutely, absolutely. Wonderful.
There
I
is
think-
also something to comment in your view, even in these cross-sectional views, you have some microcalcifications
you
like
can see
all
that. Yeah,
over
you
your
can see that, yeah.
vessel throughout.
Yes,
So
yeah.
sometimes when those ones are very deep, the OCT doesn't have the diameter to be able to see those ones, and those ones may have been the reason why you couldn't get like perfect position between the old stent and the new stent as well. Sometimes seeing those calcifications after post-PCI is quite difficult, so that may have been a factor as well.
Oh, yes, absolutely. And actually, if you looked at the first run of the RCA, the proximal RCA is pretty heavily calcified, so there's not that much of luminal encroachment. I thought that might create problems getting the stent down, but that actually didn't interfere at all.
And then your image from the minimum lumen area is a beautiful image as well, because it's like you don't see, it's the only segment when you don't see the stent struts that they
Yes.
almost disappear. So
Completely.
if you have this in an OCT in a stent failure, you have the answer of neoatherosclerosis
Sclerosis,
right
yes.
away. So it's very easy to find those segments. Then if you are not able to see the stents behind, there is some neoatherosclerosis with lipidic infiltration. So you have the answer right away.
Even the time duration strongly suggests that this is neoatherosclerosis.
Oh, yes, of course, yes. I think,
Absolutely.
and temporarily, yes, it had to be neoatherosclerosis.
Neoatherosclerosis,
I think
absolutely.
the ruptured plaque just confirmed the fact that you had atherosclerosis there that ruptured.
And then absolutely.
But doing imaging, you can be quite surprised. That was my approach before. It's like, okay, this is a vermeral stent that is 10 years old, so this is a neoatherosclerosis. You will be surprised how few times it's not neoatherosclerosis, and actually you don't have to deploy another stent. I agree that most of the cases are like that, but if you don't do imaging, you cannot be confident of what is the mechanism.
Yeah.
Okay.
It was an excellent case, sir. Excellent discussion. And since we are out of time, already 9:30 now.
Yeah, I think
And I thank both the presenters and Natalia to be here with us. And it was a great contribution from your side. And all our moderators, Dr. Bahulian, sir, Dr. Sahu, and Dr. Sahib. Uh, so everybody, all moderators. And today it was a great second day meeting. We had 3 high-profile lectures and a very good debate, an informative live case, and a good case-based discussion now. And we had 10 exciting expert strategy discussions by all the experts from the country, all over the country. And both days we had close to 1,000 attendees. And today it crossed more than 500, and yesterday also 500 plus 650 attenders yesterday. And I thank each and every faculty for today's session and each one of you for your attendance and participation in today's program. I look forward to see you again tomorrow at 5 p.m. for the approach for the management of calcified lesion in coronary artery disease. And for tomorrow, we have Michael Kurkov from US and Giulio from Italy to highlight us in the treatment of calcification as well as OCT in calcification. And of course, we have all our national faculties and around 10 case presentations to be done tomorrow, and a live case from Calicut. It's a calcified lesion being done live. And I'm sure that we will have a good, exciting another day tomorrow. Till then, take care, stay safe. Good night to all
Good night,
of you.
everyone.
Thank you very
Good
much.
night, everybody.
Yeah.
Bye-bye.
Bye-bye. Good
Thank
night.
you.
Bye.
Bye-bye.